So Ph-positive ALL is a acute leukemia that's very aggressive, and it's historically been a really feared leukemia, particularly by adult oncologists treating leukemia patients, because this is a subtype of disease that has been chemotherapy resistant, and historically these patients were hard to get in remission, hard to maintain in remission, and often relapsed. That all changed with the invention or the development of tyrosine kinase inhibitors. These magic bullets have really transformed this disease, and now, frankly, it's a very satisfying disease to treat because we can get these patients into remission, we can get them into deep and durable remission now with tyrosine kinase inhibitor-based inductions with minimal toxicity, and patients do very well when they're consolidated with chemotherapy, transplant, and novel agents, various approaches there. So everybody agrees that tyrosine kinase inhibitors are great, and that everybody with Ph-positive ALL should have their therapy based on a tyrosine kinase inhibitor. But where there are still unanswered questions is what is the best tyrosine kinase inhibitor to use, and in which patients. After the invention of Dasatinib, it's been exciting to see the development of second and third generation tyrosine kinase inhibitors that are more potent, and specifically the third generation tyrosine kinase inhibitor, Dasatinib, has the advantage of decreasing relapses through the so-called gatekeeper mutation T315I. But these more potent TKIs also have different side effect profiles, specifically more challenges in terms of cardiovascular and pulmonary toxicity. And so what the field is trying to understand is which patients should be getting second versus third generation TKIs, and whether that should be tailored based on the patient's risk. For instance, whether or not they have additional high-risk genetic features, whether or not they have evidence of having antecedent CML, and also based on their age and comorbidities. So I think we are in a fortunate position to have multiple TKIs, and we are refining how to use those in our patient population. Another particular area that I'm particularly interested in is potentially combination TKIs, and we have an ongoing phase 1 trial, multi-center phase 1 that I'm leading from Dana-Farber and with colleagues at other institutions, where we are combining Dasatinib and Asciminib, an ATP binding site TKI as well as an allosteric inhibitor, with the hope of offering a oral dual TKI-based therapy that can offer deep and durable remissions. And so we're excited about the early results, which are showing that it's tolerable, and we are excited over the coming months to a year or two to present our data at academic meetings and develop this regimen further.